right, welcome those of you who are logging in. I'm going to give it a few more seconds here just to let people log in here. It does sometimes take a little bit for people to trickle in. Good afternoon, everyone. Thank you so much for joining us. And I do see that the number is continuously changing here, so I'm just going to give it a few more seconds here before we get started. And then after that, we'll just allow people to come in as needed. All right, so I think, yeah, it looks like people are going to be still coming in here. But I am going to get started in the interest of time, and people hopefully will be trickling in as we are doing the housekeeping slides, as not to miss anything. Good afternoon, everyone. Thank you so much for joining us. This is the Epilepsy and Emergency Medication webinar. It is October 21st, 2020, about 5 p.m. here. This is provided by the Epilepsy Foundation of Minnesota. Before we get into the content, there are going to be some housekeeping items I do want to go over. This is an hour-long webinar, and in regards to bandwidth, if you have applications like music applications or video applications, things like YouTube or Pandora, we do recommend that you have that shut down in the background, and that's because having those on can affect the way that your webinar plays on your end. It could slow things down or even affect the audio, so we do recommend that being turned off. Other applications such as your email can also affect the way that this webinar plays. So I do recommend that you have those things shut down. In about a week or so, you will get a follow-up email, and in that email, there will be a certificate of attendance for you attending the entire webinar. So give it about a week, and we will be sending that out. And if for some reason you do not receive that, or if you have any other follow-up questions, in a few slides or so, I'm going to be reading off my contact information, and you can contact that. And this webinar is being recorded, so if you want to watch it later on or watch it again or maybe send it to somebody else, it will be posted on EFMN's website in the near future. We do have the chat function disabled for this webinar due to the amount of participants, but you can definitely ask questions. We're taking questions at the end of the webinar, but please feel free to put those questions in at any time because we are monitoring that. Me and another staff member will be monitoring that throughout the webinar, so you can enter those at any time. In regards to any tech issues you may be experiencing, we do not have any tech capabilities on our end. Unfortunately, we are all working remotely. But if you do have any issues, I know that in the past, sometimes what helps is logging off of the webinar and logging back in. Perhaps you might want to restart your phone or your computer that you're watching this from. Anything beyond that, though, you are probably going to want to connect with that Zoom tech support. You can also put a tech question in the question and answers area if it's something that seems pretty simple, and we can troubleshoot there. Again, we are monitoring that, but I do recommend that you contact Zoom tech support because that is probably where we're going to have to send you. My name is Jamila Pickett. I'm the Senior Coordinator of Education at the Epilepsy Foundation of Minnesota. And really today I'm going to be just facilitating some of this background stuff as we let the guest speaker go through the content. My main duties are providing educational programming throughout Minnesota and Eastern North Dakota. If you would like to contact me, I'm about to read off my email and phone number for those of you who maybe cannot see the screen, or maybe if you're calling from your phone. So just to have something ready so you can write that down if needed. My email is jpickett@efmn.org. Again, that is jpickett@efmn.org. Or you can call me at 651-287-2315. That is 651-287-2315. Also would like to introduce our guest presenter, Dr. Patricia Penovich. She's bringing a lot of knowledge and background to this webinar today. Dr. Penovich is the chair-elect of the EFMN Professional Advisory Board. She practices with Minnesota Epilepsy Group since 1992 and is now an emeritus there. She's also the adjunct clinical professor in the Department of Neurology at the U of M, or University of Minnesota. And she has actively been involved in resident education in epilepsy at multiple locations in her career, as well as providing physician leadership in the Allina healthcare system. Her passion in epilepsy care has been the care of women with epilepsy, and her clinical research has centered in the investigational new therapies for epilepsy. I also want to read off a quick disclaimer before we get into Dr. Penovich's information and content. The information shared in this webinar is to inform you of the aspects of epilepsy. However, all potential treatment options should be discussed with your medical provider. We have some further disclaimer information and relationship information there as well. And then today's objectives. So from this webinar, you should be able to define epilepsy and seizures, attain an understanding of what emergency medications are, learn the appropriate emergency medication practice, and increase the knowledge of available treatment options. All right, so there are going to be some polls throughout this webinar, and we're going to test one out right now. So I'm going to start our first poll. All right, and you should see it on your screen here. So the first one is, have you ever attended an Epilepsy Foundation of Minnesota webinar? And I'm going to give you all some time here to answer this question, and then I will share the results. All right, almost all of you have answered. I'm just going to give it a few seconds here. All right, so let me share those results. So it's 50-50. So 50% of you have attended one before. Welcome back. And 50% of you have not. So welcome. And I do hope that you enjoy the webinar. All right.
Next slide.
Thank you. And I will turn it to Dr. Penovich.
Good evening, everybody. I hope we're all warm on this continuing snowy weather we're having. I know there's many participants on this webinar who have different experiences with seizures and epilepsy. I want to make sure we're all on the same page and understand that epilepsy itself is a neurological condition that's characterized by recurrent seizures, which are unprovoked. So what that means is that if somebody has a reversible condition where they repeatedly have low sugars and have a seizure, that is not epilepsy, that is a provoked seizure. If they have a seizure because their calcium's too high or too low, or their magnesium is too high or too low, that is not epilepsy. But epilepsy is, again, recurrent, unprovoked seizures. Other people have called epilepsy a seizure disorder or a condition. And indeed it is. There isn't one cause for epilepsy. There's many causes we shall see. Next slide, please. So this is a diagram that shows multiple reasons why folks can have epilepsy. And what we should say is that just because you have one of these factors in your history doesn't mean that you absolutely will get epilepsy. It just increases the risk of epilepsy. So anything that causes an injury or a defect in brain function could potentially cause epilepsy. So you may have had meningitis or encephalitis in the past, or had a difficult birth and or premature, or have a malformation of brain development called a dysgenesis, or a tumor, or a past head injury, which was serious with a prolonged period of loss of consciousness, or a stroke. But about 50 or 60% of the people who have epilepsy don't have a for sure reason as to why they may have their epilepsy. As we know more with research and as knowledge develops, we're finding that some of these people actually have genetic causes or multiple mutations in several genes that may cause their epilepsy. But again, all of these things may potentially cause seizures, which may be epilepsy if it's recurrent. Next slide, please. So what is that single seizure? What actually causes a seizure? Well, think about a seizure as basically being a short circuit. There's a sudden involvement of brain function with uncontrolled electrical activity in the brain. And that happens when there's increased amounts of excitatory activity, which is much higher than the inhibitory forces, which are in the brain through different chemical transmitters. And the way that seizure looks depends on what part of the brain is involved in the seizure. So if it was in the posterior frontal region where the motor cortex is, you may see your facial twitching or an arm twitch or your leg twitch. If it's in the temporal lobe area in the middle part called the hippocampus, you may have a particular warning or beginning of a seizure called an aura, which may result in a sense of having been in a familiar place before, or an unfamiliar place. It looks unfamiliar to you. So it really depends on what part of the brain is involved. If the whole brain's involved, depending on how the involvement is, it may be an absence seizure, or it may be a generalized whole body shaking. Next slide, please. So there are things that cause seizures or may bring seizures on, and it does not happen necessarily for everybody. But as time goes on with an individual having their epilepsy, they may recognize some things that tend to bring their seizures on. And I think we all know that if we're not taking our medication and our levels are falling, we've lost our protection and may have a seizure. If our medication is quite delayed and you're taking a medicine that has a short period or a short half-life, that may cause a seizure because the medicine level's fallen. For some people, stress, anxiety, or even extreme excitement may cause a seizure. Very, very common is a lack of sleep or fatigue, a disruption of sleep changes. For some women, the hormonal changes that go along with different portions of their menstrual cycle may cause a seizure to happen at certain times. And the list goes on as we see there. But I think one of the things that you'll notice is that it seems that a lot of these involve a change in our routine, something that disrupts our medication schedule, our sleep, our general well-being, our eating, hydration, etc. So think about if I'm taking a long plane trip to Asia and I'm crossing many different time zones, what time is it and when do I take my medication? Well, my schedule may be very disrupted. Not the least of which is also say my sleep is probably very disrupted. And you've got two factors right there that might cause a problem. Think of that student who's gone off to college, at least in times when people could go off to college, and it's now exam time and you haven't really done everything you have to do, and you've got a lot to do before that test in the morning, and you forget to go to sleep and you forget to eat and you didn't take your medicine. And then all of that leads to potentially having a seizure. And then maybe, you took some alcohol after that exam and you have a seizure as well. So even things like excitement, as I said, I've had many patients tell me that every time you're going to go to a very special event, they get so excited, and that really tends to bring a seizure on for them. So next slide, please. So oftentimes we'll talk about having an emergency medication available to help for those times where we may be more susceptible to having a seizure. These medicines are not daily medicines. This is not something you take on a daily basis, but they're what we call PRN, or as needed medicines. And when you take those and which ones you take really should be defined in conjunction with your healthcare professional and yourself and your caregiver. And these may be taken at times when your seizure pattern changes, and we're going to talk more about this later on with respect to the frequency, the severity, or the length of the seizure, or some of those high-risk times we just talked about. Okay, next slide, please.
All right, so we're coming up onto our next poll here. I'm going to share that second one and give everyone some time to answer it. So our next poll is, do you have an epilepsy rescue medication at home or an epilepsy emergency medication at home? And it looks like those answers are coming in, and I'll allow for those last few people here to answer. And it looks like we're just waiting on a few more people, so I'm just going to give it a little bit more time to allow those last few people to get their answers in if they would like. So the question is, do you have an epilepsy rescue medication or emergency medication at home? So your options are yes, no, and I am not sure. And I'm going to give it just about 5 more seconds just to allow the last few people to put in their answer. All right, let's look at those results. So it looks like a good majority of us here actually don't have one of these medications at home. So 88%. And then we have 13% here who are viewing maybe for that personal use. So it is great to see that breakdown here. All right. We'll move on to the next slide. And on this slide, we have another poll that I'll share with you all. And our next poll is, have you heard of a seizure action plan before this webinar? And again, I'm going to allow people to answer that question. This will give us some insights here going forward into our next topics. Awesome. It looks like a majority of people have answered so far. I'm going to give it about 10 more seconds here to allow those last few people to answer. All right, let's see those results. All right, so 100% of you actually have heard of a seizure action plan, which is awesome. And so some of this might be review coming up, but it's definitely some in-depth information that is helpful to understanding emergency and rescue medications. And I'm gonna send this back over to Dr. Penovich.
Thank you, Jamila. Well, I'm really impressed that so many folks on this webinar have a seizure action plan, because the polling that's been done recently, at least for the people who answered that poll, said that 70% of the adults and 55% of the pediatric responses did not have a seizure action plan. So I guess you can imagine that I think it's a pretty important factor in taking care of folks who have seizures, and for you folks to advocate for yourself to have one. So we're going to discuss those in a little bit of detail. So this is a plan that's individualized to you and for you by yourself and your caregiver in concert with your healthcare provider. And it should be concise, shouldn't go on for 10 pages, okay? It should be understandable and can be easily updated when changes are made to your medications. So it's a document that helps you and the folks around you prepare for when a seizure does happen. What should they do to respond to you, to help you? And it should be easily available to them. And let's sort of say the EMS comes into the home. Here's their plan and here's what we've done so far. And very clearly, because when you have epilepsy, there's changes to medicines, there's potentially changes in VNS if it's been programmed. There's been changes as to what your seizures may look like as your control has hopefully gotten better over time as well. And so those changes may make changes in your plan. So your plan should also reflect the changes and should have a date that says this is as of this date, okay? Next slide, please. So the ideal plan, as we noted, is developed as a team. Your care with your epilepsy should be a team event between you, your caregiver, and your healthcare provider. This goal for this plan is to provide management and guidance to clarify and provide a home management program for you. And hopefully what this will do is to provide an early treatment and basically end up avoiding the need for a transport to be called for you to be taken to the emergency room or to the hospital for something that maybe could have been controlled and not gone on that far. The other part is to, again, help that communication among yourself as the patient and your providers and potentially the hospital or EMS personnel. Again, so important to have it kept up to date and have it be sent electronically, or you should have potentially a copy in your wallet or on the refrigerator door, wherever you put those important documents. It may also provide the direction for other therapies that you may have that may not be medication related as well. So like when to swipe the VNS magnet, how many times, etc. And then very clearly guidance for when you actually should have a concern to call the EMS. Next slide, please. So here's that important seizure action plan. It has many components, as we've said, and even though there's a lot of components here, it still can be done in a fairly short form. So it clearly is going to identify who you are, the date that this plan is effective as, and who is your healthcare team, and how do you get hold of them? And then kind of defining in a very brief way what your seizure looks like, how long it usually lasts, and what happens during it, and what tends to have brought it on. But really importantly, what medications that you take on a regular basis for your epilepsy, but also potentially your other medications, because potentially there may be some interaction with that other medication and your present medication, or you've gotten a new medicine for a new condition that hasn't been recognized as maybe being likely to lower your seizure threshold itself and make it more likely for a seizure to happen. There should be some directions for how people respond with you at home or at your workplace or at school. Obviously, some early first aid things like depending on what seizure type you have, and then when and how to give your rescue medication. Next slide, please. So who's that seizure action plan for? Well, it's obviously for you because you're the person with the epilepsy, but it's very important for various caregivers who may have contact with you. And particularly those who don't maybe see you all that often and may not remember because they haven't seen you for a few weeks what goes on. So a babysitter, if your child has seizures and you say, I really need a night out, and it's we all need a night out right now. It's time to go to a restaurant or a movie, and here's a good babysitter I can trust my child with. The grandparents who said, okay, you young couple, you get to go off for a weekend on your own and we'll take care of Joey. Well, they haven't probably taken care of Joey for a while, so they need to know what to do, as well as for spouses or significant others when things happen. And for spouses, oftentimes that may be something they're in bed and waking up because you may have had a seizure. Think about a residential staff. Many different staff rotate through on different shifts and different days, get assignments to different clients, and so may not be perfectly up to date or remember what happens on a regular basis. So if that seizure action plan is there and easily reachable, they're going to know what to do quickly and efficiently. School nurses and staff, all of these kiddos who are going to school, they want to have a good experience at school and a good school environment. So if something happens, it needs to be recognized and taken care of, and in a calm and efficient way. Seizure action plans can happen at the workplace, in other medical facilities you might go to that don't have as much experience with seizures as your neurologist's office does, and where people might get frightened and be concerned. And that's why having that seizure action plan potentially in your wallet or purse or something would be helpful, or maybe on your cell phone. There's some thoughts about making apps to have that available on the cell phone as well. Next slide, please. So we're going to watch a short video here with Patty Schaefer of the Epilepsy Foundation of America about seizure action plans.
Everyone with epilepsy should have a seizure action plan. It's very important for someone who can't communicate for themselves or can't advocate for themselves, but it's really a benefit for everyone with epilepsy. It's a place to keep all that critical information in one place so anybody can have access to it. And more importantly, you feel safe knowing that people will know what to do. If you're a person that might have a tendency to long seizures or cluster seizures or things that happen different from usual, the seizure action plan is a place to record what they normally look like and then what could be a potential emergency for you. And then most importantly, what medications you take daily, but what are these as needed or rescue therapies? And they need to be clearly spelled out as to what they are, how much to give, and when to give. Keeping in mind that if it's not something you take on a daily basis, or you need someone else to give it to you, you want to make sure that you have it written down accurately, what to take, when, and how.
Next slide. So the seizure action plan is something probably the schools are reasonably familiar with, because every August our office has gotten, we need this before the first day of school. And the reason for that is we want everybody at the school, administratively, teacher-wise, and school nurse-wise, to know what to do. We want the classroom to be calm when suddenly there's a seizure and there's not a ruckus in the classroom, making it even a bigger embarrassing event for a child. And we want them to know when to call 911. We know that with our seizure smart schools, many more schools are getting the message about how to use these plans to make it best for the student at school. So the teacher and the staff should know where the SAP is located at school. Sometimes the nurse has it, but certainly the teacher probably really needs to have it as well. And be clearly aware that plan is there, and there should be good communication between the family and the school as well. Next slide, please. So, many schools don't actually have a school nurse on site, and you would sort of say, well, how could my child have a seizure action plan if there's no nurse? Well, the nurse can designate somebody else at the school and train them so that they can have the ability to carry out the tasks on the seizure action plan. There may be some limitations based on the local policies and laws with respect to how much they can do at the school before a seizure action plan, i.e. with respect to administering a medication, is appropriate. And some of that may be changing now as well, because we have some different medicines that may be able to be administered in a much more acceptable way than some of our past medicines. And we'll talk about that in a minute. The school nurse, as I said, can delegate somebody else appropriately. The nurse will train that person and assess their competency to carry out those chores. And then the nurse should be involved, or the designated person involved, in assessing how the student is doing with the seizure as it goes on. Next slide, please. The workplace may be a little bit harder because it oftentimes is not as structured with respect to healthcare professionals on site. But some of them do have medical facilities on site, and if so, they should have the seizure action plan as well. But I think one of the important things to also really be cognizant of is that it would be good for disclosure and realize that disabilities are, and the laws are such that you cannot be discriminated against because you have a disability or seizures. So for you to disclose and say, here's my seizure action plan. So if something happens at work, they can react appropriately, give you timely treatment and direction about should they or should they not call 911. And the other thing it will do if you've got your coworker or your employee involved is it takes away that fear factor. If they suddenly, there's a seizure and they see you have it, if they haven't had any forewarning, it just accelerates and fans the flames for anxiety on their part as well. Next slide, please. So seizure emergency factors. When should we think about when a seizure is an emergency? Well, by definition, when a seizure lasts a long time. If you're watching somebody have a seizure, it seems like an eternity, but usually most seizures are over within a minute, 2 minutes at the longest. So a seizure that's 5 minutes or longer is really a concern. And we actually, by definition these days, are now thinking that a 5-minute seizure is on its way to becoming status epilepticus. So we actually begin, if you're in the hospital and that happens, begin emergency treatment at that 5-minute mark, if not before. Some of that depends on what your usual seizure pattern. You know, if your usual seizure pattern is your seizure's over all the time before a minute, and now it's 3 minutes, maybe you start the plan before 5 minutes. When seizure clusters occur is an emergency time, and we're going to talk about that in a minute. But seizure emergencies are unique. What's your seizure emergency may be very different than what the person sitting next to you's seizure plan might be. So for instance, if Joey usually has 1 seizure every year and he's had 2 seizures every day for the past 2 days, that may be an emergency situation for Joey. Whereas Tommy, who has a seizure every morning, which is usually 30 seconds in duration, and has now had 3 to 4 seizures every day for the past 3 days, that says something's going on for Tommy, and that's a relative emergency for him. So you have to define individually what's an emergency for that patient. Next slide, please. So I use the word cluster seizures, and that term has received a lot of attention in the last few years because of the research that we've been doing for treating cluster seizures or acute repetitive seizures. That's the same name, same thing. And what it refers to is a situation in which the seizure pattern is different and unusual from the patient's usual seizure pattern. So it could be that the seizures are happening more frequently, or the severity is more severe, or that you're having a clump of seizures within a time frame that's much more unusual than your usual. Be that a 4-hour, a 6-hour, or an 8-hour time. It sort of depends on what your usual pattern is, or be it 24 hours. But some of these time frames were what were defined in the research studies, and that's why they're up here as definitions. And the seizure action plan is then mapped out in order to direct you in these different scenarios. If Joey is now in that, having had 2 or 3 seizures today and his usual frequency is 1 a year, what to do to bring him in control before it becomes a more severe emergency and requires a transport. Okay, next slide. So we're going to have Patty talk to us about when you should use rescue therapies.
Seizure clusters or periods of increased seizures are one time when rescue therapies are used. So everybody's got their own pattern. So trying to figure out what cluster is an individualized one. Is it a certain number of seizures over a period of time? Is it a change in your pattern? So if you're used to having seizures over just a couple days and now you're having them 3 or 4 days in a row, that might be a cluster for you. Another time rescue therapies might be used is if a person's going through what we call a high risk time. So if a person knows that stress affects their seizure, or when they get sick with a cold or a flu or an infection, that they're more apt to have seizures, or when they're more sleep deprived, their doctor or nurse might recommend that they have a rescue therapy on hand for that reason. So if you know you're going into that high risk time, they might say before your seizures get worse to try to use that rescue therapy. Or if your seizures start acting up when you're sick or when you're sleep deprived, to not wait, but to take the rescue therapy early.
Okay, I would add to that, taking that Asian trip I talked to you about, you know that you're going to be on a plane and the schedule is going to be disrupted. That might be another time to use it. Okay, let's try the next slide, okay? So there is no perfect medication. I want you just to say that up front, okay? But we know there's some ideal characteristics that we can shoot for in a medication. We want one to be potent, meaning it works quickly, and it works like almost all the time. That after you use it, or when you use it, you have minimal side effects that disrupt your function further. That it's easy for you to use or your caregiver to use, and that there is easy dosing such that doses can be individualized for your size or your age or whatever. Next slide, please. So we're going to talk about those medicines. This is where we get a little technical, and I'm going to try not to make it too tough here. But the nice part about this is that all these medicines basically belong to the same chemical family called the benzodiazepam. So diazepam or Valium, lorazepam, which is Ativan, clonazepam, which is Klonopin, midazolam, which is Nazolam. Those are all benzodiazepines, although each one is a different chemical. And they've all basically been used in emergency settings on the EMS trucks, in the ERs, in the hospital by IM and IV use. And they've worked well. But you can't do that at home because you don't have an IV in, and most people don't want to use IM injections at home either. So we now have several medications which are available for out-of-hospital use, and that's the diazepam rectal, the midazolam nasal, and the diazepam nasal. There's another one in trial called alprazolam, and there's another one at the FDA, which is a little oral strip that you place on the tongue, and it's a diazepam as well, but that's not available yet. Next slide, please. So we have the different approved rescue therapies outlined here. The rectal diazepam is Diastat, and the initial approval for Diastat came in 1997. So it's been around for a long time, and the pediatric users are well familiar with this medication. Its use extended down to 2 years, and its onset of action is pretty quick, within 2 to 5 minutes usually, but sometimes it may take 10 minutes to use. And a potential side effect outside of the somnolence that any of the benzodiazepines can cause is diarrhea. The intranasal diazepam is Valtaco, and that was approved in January of this year. Because it's diazepam, the studies did not have to prove that diazepam works against stopping the seizures, but they had to prove that it was safe in this format, and look at the pharmacokinetics when given in this format. So the time parameters are the same as the rectal diazepam, and the side effects are mild and transient nasal discomfort or an abnormal taste for usually just a few minutes after use. And we'll talk a little bit more about that. The intranasal midazolam or nasolam is approved for 12 years or older. And its time frame is in the same neighborhood as the diazepam as well. And it can cause sedation as well some mild nasal discomfort as well. All of them as benzodiazepines carry warnings for use with glaucoma and the side effect of sedation and particularly CNS depression if you're using pain medications such as opioids. So that's a warning there. Next slide, please. So if we dive down to the rectal diazepam, diazepam is useful in treating any of these seizure types, which basically means any of them, okay? Either focal seizures or primary generalized seizures or secondarily generalized seizures. The instructions about how to use it will be included in the prescription as well with respect to dosing and when to use it. And that should also be on your seizure action plan. It can be stored at room temperature and it has up to a 3-year shelf life. The difficulties in using rectal diazepam occur because you think about how it has to be used by rectum. So the patient has to be basically lying down on their side with their pants down, and that can be socially uncomfortable for both the person giving it as well as the person receiving it in a out-of-home situation. So it's maybe easier to use in infants at home and in situations where infants are used to be treated. Next slide, please. Some consideration is, although we don't know 100%, we do know that diazepam acts at a receptor which is inhibitory, increasing that inhibitory tone within the brain to cut down that electrical circuit, which has gone short-circuited. It works pretty quickly. It peaks concentration-wise. It is bound to the proteins in the blood and it is metabolized in the liver fairly quickly. It's been found that the levels, if you give the same dose to the same person over time, it's very variable as to what the concentration will be in the blood. The common side effects include any of those things you can think about with a Valium being given to you if you took a pill. Fatigue or clumsiness, sedation, maybe some blurriness of vision or dizziness. Okay, next slide. So the intranasal diazepam is still diazepam, so it still treats the same kind of seizures, any of those seizure types. As I said before, it's approved for individuals over the age of 6, although there will probably be consideration to lowering that as well to 2. It comes in 5 milligrams, 7.5 milligrams, and 10 milligram nasal applicators in a small volume of just 0.1 milliliters. It's very small. And the little atomizer is very much like what you might see with a neosynephrine or an Afrin applicator or other nasal medications. So the person who gives it can use one hand. You don't have to prime a pump and pretty easily given. So the 10 milligram and 20 milligram and 15 milligram, I'm sorry, the 15 milligram and 20 milligram doses, if you require that much because of your weight or what you need, are actually 2 not injectors, but atomizers in the blister pack for 1 dose. The 5, the 7.5, and the 10 milligram doses will be 1 atomizer in the blister pack. And each box that you get from the pharmacy has 2 separate doses. If you need a second dose, you should wait 4 hours. Those are the same directions you'll see with the rectal diazepam as well. You shouldn't use more than 2 doses in 24 hours. Let's go to the next slide. And you shouldn't use more than 5 times in 1 month so that you don't build up a tolerance to the benzodiazepine effect. Your medical provider will give you any specific directions. It stores at room temperature. You don't have to prime that pump. And like all these medicines, they should be kept out of reach of children. Next slide. The intranasal midazolam is very similar in the sense of the atomizer. In fact, it's the same kind of atomizer, treats the same kind of seizures. It's a dose, 5 milligrams in that same small solution applied in one nostril. A second dose can be given in 10 minutes, and you should not use more than 2 doses in 24 hours. There have been midazolam nasal given that were formulated in special pharmacies that were large volumes of 5 milliliters and very difficult to use. So this is the commercial preparation. Next slide, please. Again, same reason, not using it more than once every 3 days or 5 times in a month. Sometimes doc will want you to do a test dose to see how you react to it in the office. And again, like any of these, if the cluster continues on, you should seek medical attention and look at your seizure plan for when to call EMS. Next slide, please. Okay, so the thing to know for all of these medicines is that they're all effective, they're all potent, they work quickly, and they all have prepackaged doses, so they're easy to use. The side effects are basically all similar and predominantly somnolence. And the intranasal preparations are particularly much easier to use, and they're potentially quicker to use, and they're more socially acceptable, particularly for older children, adolescents, and adults, which means hopefully that we'll all, when we take that poll the next time, we'll see that many more people have rescue medications. Again, you should clearly be aware of when to call 911, and this will be on your seizure action plan as well. Obviously, if it's the first time somebody's had a seizure, 911 should be called. If there's a severe injury, the patient is blue or cyanotic. If it's a 5-minute or longer seizure, it's status. If it was in water, they may have aspirated water and it's in the lungs. If they're in danger from other medical conditions, or if you yourself feel really uncomfortable, you should call 911, okay? And I think that ends my part of the presentation, Jamila.
Thank you so much, Dr. Penovich. All right. So we're going to be going through a few more slides here before we get to questions. But please, as we're going through these last slides, they're not as content-based. They're more resources and information. So this is a really great time for you to enter any remaining questions that you have, and we will get to that at the end here. So we have some resources for you. One that's not listed here, but it's pretty much on every page, is we do have seizure action plan templates that EFMN can provide on our website or can be sent to you. We have them both for youth and adults. So that's something that we talked quite a bit in this webinar about. So that is an area that you can definitely reach out for. Since we've gone into this more virtual world, we're finding that there are many people from all over the country outside of Minnesota and Eastern North Dakota, and actually outside of the United States watching as well. So if you do have any questions, or if you do need more resources around this, please feel free to connect with your local Epilepsy Foundation chapter or affiliate. You may also contact the Epilepsy Foundation, the national resource, if you're not able to find one in your area, and they may have a place to point you. There's digital pharmacies, and this is something that's going to be coming in your follow-up email as well, and you can click these websites, as well as assistance tools for your prescriptions and medications, such as Medical Assistance Tool and RX Hope. The Epilepsy Foundation of Minnesota also has information services that we can provide. It's going to be free one-on-one support that can be customized, that has customized tools and resources around a varying amount of topics related to epilepsy. You can also request materials through this service as well. Our Senior Coordinator of Information Services is Debbie Leone, and I'm going to read off her email here a couple of times for those of you, again, who are on the phone. If you would like to utilize these services, or if you have any questions about resources around epilepsy. Her email is dleone@efmn.org. That is let me start over again here. DLEONE at efmn.org. Hope you guys caught that. And then our phone number is 651-287-2303. That is 651-287-2303. And at EFMN, we lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. You can contact EFMN generally on our website, efmn.org, or call us at 1-800-779-0777. Or you can also contact one of the numbers we previously mentioned, and they can direct you to the correct person to connect with. And if you would like to make a donation, please visit our website as well, or you can press this link directly when you get the follow-up email. All right, so please continue to enter in any questions that you have. I'm just going to be going through these references here for the recording, but this is a really great time for you to enter any other remaining questions before we get to that last slide, and then we will cover that. All right, so I will be taking questions now. And please feel free to enter them as we go. I have one question here, and I think I'm going to direct most of them to you, Dr. Penovich, and if there are any that are more EFMN related or anything like that, I can take them. We have one question here. It is, who creates the seizure action plan?
Well, there's the old way where it used to be the doctor, but I think the way to appropriately address that is you ask and should say to your provider, be it a doctor, a nurse practitioner, physician's assistant, or whatever, so your healthcare provider, that you would like to have a seizure action plan so you can be prepared. And you should have sort of a discussion at the same time in creating that plan. And as we go forward, we're going to hope that that's created while you're there. So there's discussion and everybody understands it. It's a great time to actually have some education and be sure that you understand your seizures and your epilepsy at the same time. Because I know we all listen to somebody talking to us in the office. I'm there too. When I'm a provider, it's like, now what, I leave the office, now what did he say about that? So it's another way to put all that into one framework and get a big whole picture.
Thank you. Another question that we have here is if we can just go over the when to call 911 again. And I'll actually just go to that slide here for you, Dr. Penovich, so you can use that as you're talking here.
Okay. So if you're with somebody and out of the clear blue, you don't know anything about them, or it's your best friend and you do know something about them and you see them have a seizure and you think this is the first time, that's a time to call 911, because that person clearly had a new event that they didn't know about and you didn't know about. If there's an injury, so it depends on what's the severity of an injury. If they bumped their arm, that might hurt afterward, but it doesn't mean you have to go to the ER. On the other hand, if you've got, they fell onto something really sharp and are bleeding pretty briskly, you need to call 911. If they're blue, well, the word is cyanotic, their respiratory pattern is they're not breathing, and it's like geez, should I start to do CPR? You call 911 or have the person behind you call 911 while you're doing CPR. If it's one of those long seizures and it's longer than 5 minutes, you've already used your rescue and the seizure is continuing, it's longer than 5 minutes, 10 minutes for sure. If the patient was in a swimming pool and this happened, they probably pretty clearly got water in their lungs and they're at risk for other complications and should be transported. If there's some other concern that you've got for their health condition at the same time, if you feel like, man, I don't feel comfortable, they don't seem to be responding, it's not quitting, I don't feel comfortable, even though I've got the seizure action plan, it's not going to help them if you're hesitating to do it, even though you have it. But if you feel comfortable with the seizure action plan and you've done it and you're uncomfortable because they're not doing what they're supposed to do in response to the seizure action plan, then that's a time to call too.
Thank you, Dr. Penovich. Please continue to enter in your questions if you have any here, and we will answer it. We do have a few more minutes here. Another question that we have for you, Dr. Penovich, are all seizures considered emergencies?
It depends kind of what situation you're in. If you've had controlled epilepsy and you suddenly have a breakthrough seizure, then I would say in that scenario, that would be a relative emergency, okay? So even a person with controlled epilepsy should have an in-case seizure action plan. I don't think we talked about that before. No, I don't think otherwise all seizures are emergencies because most seizures, as I said, are over within a minute or two. Patient will recover. Now, if they don't recover in their usual time frame, that could be an emergency because it might mean that they're having unknown subclinical seizures. We're getting into the details here that can make it tough to think, but an individual single seizure that looks like the patient's usual seizures, no. But if they're really accelerating in frequency, in duration, looking new or different than they ever looked before, it deserves a second look and thinking about whether it's an emergency. At least a call to clarify that to your health provider's office.
Wonderful. All right, so it looks like we have a few more minutes. We just got another question here, so please continue. We do have time. Another question that we have, are or have nasal applications replace them?
I think they're talking about intensols.
Okay. Yeah, so are intensols still being used or have nasal applications replace them?
I think you can pretty much think that the nasal ones will replace them because the absorption through the nasal mucosa is going to be quicker than what the intensol will get into. We used intensol because we didn't have anything else, and that was better than rectal diazepam for our adults. But just what we call the pharmacokinetics, that time to entry, is much quicker and probably less variable.
Okay, wonderful. All right, I'm not seeing.
Oh, can I say something else about that?
Yes, please.
The other thing about the intensol is you have to think that it didn't leak out of the mouth or was swallowed appropriately, and that's the advantage for the nasal. When you put that little atomizer in there and you squeeze it and it's going up, there's no way it's not going where it's supposed to go. And the diazepam intranasal actually has a component within the liquid that actually carries it in through the cell barriers and gets it through the mucosa into the brain. And it bypasses that initial liver metabolism. So that may be also contributing to a much tighter, or we say more predictable serum level.
All right, awesome. Thank you so much, Dr. Penovich. I'm looking at the time as well as our questions and answers area. It looks like we have 1 minute here, so I don't think we'll be able to answer another question in
Okay.
that time. But if you do have any further questions that we weren't able to get to, please feel free to reach out to us at the foundation or contact one of the contact informations that I put on here. On our screen here, I am going to leave us off on my contact information. But I do want to say thank you so much for joining us tonight. Thank you so much, Dr. Penovich, for sharing your knowledge and expertise in this area.
I want everybody to go out and advocate for their own seizure action plan and a rescue medicine. Well, you all have your seizure action plan, but now get your rescue medicine.
All right. Well, on that note, thank you all. I hope you enjoyed this webinar and learned something. Good night, and thank you, Dr. Penovich.
Thank you to all. Take care.